In a recent case reported by the Agency for Healthcare Research and Quality, an 84-year-old woman was admitted to the hospital with an exacerbation of COPD. Normally, she was on 1 to 2 liters of nasal cannula oxygen at home, but when she was admitted, she was placed on 4 liters by nasal cannula. The next morning, she was found to be very somnolent with an oxygen saturation of 98%. When they did a blood gas, they found a CO2 level of 101. What went wrong?
Nurses often ask me, what is the appropriate amount of oxygen to deliver to a patient who has COPD? This is a complex issue and involves both oxygenation and CO2 and the possibility of CO2 retention. My name is David Woodruff, and I am the president of Ed for Nurses, where we empower nurses to become extraordinary. Join me for this, one of our 101 tips to improve your nursing care: oxygen and the patient with COPD.
Before we talk about the specifics of oxygen therapy in patients who have COPD, let me backtrack a little bit and tell you about the normal anatomy and physiology and what happens when our patient develops COPD. Now, if you take a look at the two pictures here on the screen, we have the normal alveoli and the patient who has emphysema and what their alveoli look like. Notice the normal alveoli have kind of a grape-like cluster, and the picture above is the vasculature. So the vasculature is kind of a net that surrounds the alveolus. Over to the right, we have something that looks more like cauliflower. We have overinflated alveoli, and these overinflated alveoli have started to compress the vasculature that surrounds them. So if you look at the vasculature on the right, you notice that many of those vessels are compressed. Now, this is going to be a problem in trying to provide gas exchange. What happens in the lung that causes a patient to develop COPD is a chronic inflammatory process. Something is stimulating chronic inflammation. For example, cigarette smoking will cause a chronic inflammation in the lung, which leads to sputum production. That's what's called chronic bronchitis, and lung destruction, and that's what's called emphysema. As a result of lung destruction and sputum production and air trapping, the patient develops a decrease in ventilation. So when you look at the alveoli on the right, there's a lot of air trapping going on there. That's why the alveoli are hyperextended. Air trapping is occurring because we have secretions in the airways and we have bronchoconstriction, which is limiting flow. So this air that's sitting out in these alveoli does not contain a lot of oxygen. Instead, it's starting to build up a lot of CO2. Now, because the vasculature is compressed, as we see in the picture at the top, we won't have very good gas exchange in that alveoli either. All of these things lead to decreased oxygen delivery to the alveolus and decreased carbon dioxide removal from the alveolus. Now, there's two things in the patient's body that are going to help to control our levels of oxygen and our level of CO2. It's called a hypercapnic drive and a hypoxic drive. First of all, let me just take you to the picture on the screen, and it illustrates some of the things that happen with COPD. Notice we have bronchoconstriction, so the round circular piece here that we're seeing in the middle of the screen is the airway, and you notice how there's lots of bronchoconstriction, but inside you also see that green stuff, and the green stuff is mucus. So not only do we have bronchoconstriction, but we also have mucus production, and the mucus further narrows the airway, making it even more difficult for the patient to have movement of air. Now, normally our respiration is controlled by both of these different drives. We have a hypercapnic drive and a hypoxic drive. Hypercapnic means that if your CO2 level becomes high, you will breathe faster. The hypoxic drive means if your oxygen level becomes low, you will breathe faster. Now, everyone has both of these drives, including your COPDer. Many times in COPD, we hear about the hypoxic drive. But those patients also have a hypercapnic drive. They've just changed their tolerance to higher levels of CO2, and thereby they've readjusted their normal range. So their range for CO2, instead of being 35 to 45, as is normal, in a COPDer who has chronic CO2 retention, they may normally have a CO2 of 50. In which case they've kind of adjusted their scale so that hypercapnic drive won't even start to kick in until maybe they hit 70 or 80. Then they start to breathe faster. Now, this is an important concept to understand when we're talking about oxygen therapy in the COPDer. Giving oxygen to a COPDer over a long period of time can decrease the hypoxic drive. Hypoxic drive means that we're driving our ability to be able to breathe by having a low oxygen level. So if we increase the oxygen level, then we knock out that drive for the respiratory system. Now, the COPDer may have a much higher hypoxic drive than most other people might have. And in case they may have a CO2 of 80 or 90 that occurs before they start to breathe faster and start to blow off this extra CO2. So it's generally accepted that we don't want to be using high levels of oxygen in our patient with CO2 because it may cause them to retain even more CO2. Okay, we'll come back to that concept in a minute, but let's take a look at the relationship between PO2 and oxygen saturation. Now, in most cases in our patients in the hospital, we're going to have a pulse ox on that patient, so we're going to be looking at oxygen saturation. Here you got the two numbers here. The top one is the PO2, the bottom one is the O2 sat. So if you think about O2 sats, normally we like to keep our COPD somewhere in a range of about 93, 94 for their O2 sat. Now, you see that correlates with a PO2 of somewhere around 70. If we have that patient's oxygen saturation way up here by 98, like it was in this case, we've driven the patient's PO2 up to 100 or more. Now, that's not necessarily a good thing. In a COPDer, they may be very used to having low levels of oxygen, and they may not need that much O2. But there is a direct correlation between our oxygen saturation and our PO2. The higher the PO2, the higher the oxygen saturation. Take a look on the low level there. If you have a patient who has an oxygen saturation of 85%, that correlates with a PO2 of 50, just for a reference value. So what is recommended then for our patients who have COPD? During the exacerbation, maintain a PO2 of 60 to 65 with an oxygen saturation of 90 to 92%. So we may have to use 4 liters by nasal cannula, or even a veni mask, or maybe even a non-rebreather mask in order to be able to maintain this level of oxygenation. So if we have a patient who is acutely ill and we put them on an oxygen mask, a non-rebreather mask of 100% oxygen, isn't there a chance that the patient could stop breathing? Well, I suppose in theory it's possible, although research has not validated that. What are we concerned about by putting the patient on too much O2? We're concerned that the patient will stop breathing, right? So monitor the respiratory rate. If the patient's respirations start going down, then we need to start weaning that oxygen off. But during the acute exacerbation, you give the patient whatever they need, and then wean it off quickly. Now, what happened in our case here was that they put the patient on 4 liters of oxygen by nasal cannula and left her there. After her oxygen saturation starts to come up and we maintain or we get an oxygen saturation of 90 to 92%, then we need to start weaning the O2 back down. Get her over the crisis, get her over the hump, and then wean it off. So here's our quick take-home points. Treat acute hypoxia. When the patient is acutely ill, treat it. Our goals are to maintain the PO2 at 60 to 65 with an oxygen saturation of 90 to 92% in our patients who are on at-home O2. If your patient's a COPD and does not use oxygen at home, then we may go for higher goals. But these would be our goals for that patient who uses at-home oxygen. Monitor the respiratory rate to make sure that the patient does not have difficulty with breathing. Thank you for joining me for this tip. My name is David Woodruff. I'm the president of Ed for Nurses, where we empower nurses to become extraordinary. Join us online to find more tips and more information to make your practice extraordinary. www.edfornurses.com